University of Baghdad. Our subject today is the TMJ diseases. What is the TMJ? First, the temporomandibular joint are two joints between the mobile mandible and the fixed temporal bone. Each joint contains two joint spaces which are separated by a fibrocartilaginous articular disc. What's the components of TMJ? It include 8 components: glenoid fossa and articular eminence protuberance, mandibular condyle, articular capsule and articular disc, synovial fluid, and other 4 components. We have see the figures the skeletal components of the TMJ. The glenoid fossa. The glenoid fossa or mandibular fossa is a well-defined hollow area on the inferior portion of sequamous temporal bone. The convex articular eminence forms the interior limits of the joint. The glenoid fossa is covered by thin layers of fibrocartilage. The mandibular condyle is elliptically shaped with its long axis oriented mediolaterally, and the dimension is roughly 20 millimeters in the mediolateral directions and approximately 8 to 10 millimeters in the anterior-posterior direction. Here we see the mandibular condyle, the articular disc and articular capsule. The articular capsule is a fibrous membrane that surrounds the joint and incorporates into the articular eminence. Attached to articular eminence, articular disc and the neck of the mandibular condyle. The clinical evaluations of TMJ. Temporomandibular joints are located about 1.5 cm anterior to tragus of air. The two TMJs considered together comprise only one part of the total articulation between the lower jaw and the skullfacial skeleton complex. The examination of TMJ is done through inspection, palpation, and auscultation. The face is inspected for any obvious asymmetry. Scars may be indicative of previous surgeries, trauma, swelling, ulceration, sinus opening in the preauricular region. We have the deflection of the mandible to the left side here in the figure. The disorders associated with deviations, alteration in form of articular surface include changes associated with articular surface include those of the mandibular condyle and glenoid fossa. The clinical features: patient is usually asymptomatic. Over a period of time, the patient is accustomed to a new pattern of a mouth opening, as we see in this picture. The articular disc defects: we have the disc thinning and perforation. It's believed that the disc wears out over a period of time. Hence, elderly individuals may generally present with thinning of the disc, which may lose from parafunctional habits such as bruxism, clenching, and trauma. The clinical features include on auscultation of TMJ, crepitus or grating noises may be heard. In the early phases of the process, pain may be presenting complaint. As we see here in the pictures, the auscultation process, and here the MRI showing the articular disc with perforated lateral attachment. The OBG showing the flattening of the condylar head. The adherence and adhesion. Adherence refers to a transient phase in which the condylar head and the articular disc, inferior joint space or the articular disc, and the glenoid fossa, superior joint space may adhere together. The clinical features: patients may complain of a stiff jaw, a dull aching pain, and a limited mouth opening, especially if they habitually clench their teeth. However, the limitation in the mouth opening characteristically corrects following a single click when the patient makes attempts to open the mouth. While the disc displacement are also termed as internal derangement, the internal derangement could include disc displacement with reduction and without the reduction. Started with the reduction, it's characterized by an anterior or anteromedial displacement of disc up the mouth opening. However, on closing the mouth, the disc returns to a more normal position relative to condyle on opening. Here we have this video.
In this joint, the disc is anteriorly displaced, and
we see the disc displacement when the patient closes his mouth. The disc displacement without reduction. In this condition, the condylar head is unable to pass under the displaced disc. The reasons for the condyle to be trapped include thickening of the posterior band, change in shape of disc from the biconcave to biconvex, and decrease in tension in the posterior attachment. Here we see the phases of anterior disc displacement. We have the resting phase, early transitory phase, and the late translatory phase. The displacement of disc condyle complex, hypermobility and dislocation, occasionally during the terminal phases of the translatory cycle as the condyle moves past the articular eminence. It may suddenly move forward to facilitate a wide mouth opening referred to as subluxation. It means hypermobility and the partial dislocation. The dislocation, the open lock, dislocation of the condyle is a common condition that may occur in an acute or chronic form. It's characterized by inability to close the mouth with or without pain. We see here in the normal facial appearance following reduction of the dislocated condyles. And here we have elongated face in the bilateral condylar dislocations, while the OPG showing bilateral condylar dislocation. In inflammatory joint disorders, we have synovitis or capsulitis. Synovitis and capsulitis are clinically considered as a single disorders. Synovitis refers to inflammation of the synovial tissues, and an inflammation of the capsular ligaments is referred to as capsulitis. The retrodiscitis, an inflammation of retrodiscal tissues, retrodiscitis results from a traumatic injury which may indirectly cause the condylar head to impinge on the retrodiscal tissue. TMJ ankylosis is an intra-articular condition where there is a fusion between the bony surfaces of the joint, the condyle, and the glenoid fossa. The etiology, thrombomusculosis of ankylosis resulted from condylar injuries sustained before 10 years of age. The factors may be located in the etiology of ankylosis include age, type of a fracture, damage of the articular disc, and period of immobilization. We have the classification of ankylosis according to the tissue it's involved and extent in 5 points as seen in the picture. The classification of ankylosis by Togosian in 1966, type 1 fibrous adhesion, 2 the formation of a bony ridge, and type 3 the condylar neck. The grading of TMJ ankylosis, it's including type 1 flattening or deformity of condyle, type 2 bony fusion on the outer edge of articular surface, type 3 a bridge of 1, and 4 the total TMJ obliteration. The clinical features of ankylosis depends on the type of ankylosis and the age of onset and duration of ankylosis. The clinical features of unilateral ankylosis, we will see it in the following picture. We have the facial asymmetry, deviation of mandible and chin on the affected side, and other features. While the clinical features of the bilateral ankylosis includes the inability to open mouth, progress to decreased interincisal opening, typical bird face deformity with receding chin, and other features. We see the bird face deformity here. In the radiographic features in the fibrous ankylosis, joint may appear normal or the articulating surfaces may be irregular and the joint space is markedly decreased. We have the clinical pictures of a restricted mouth opening, and here the orthopantomogram showing a bony ankylosis in right side and elongated coronoid process. Thank you.